Hello, colleagues. Here is Cornel Sieber. I welcome you to this virtual meeting of the ESPEN Congress 2020. First of all, I hope that up to now you didn't have to suffer yourself or your family too much from the corona crisis, and that next year we will see one another again, not on a virtual basis. This symposium is about functional cognitive decline in older adults, and my introduction presentation will be more on the functional cognitive impairments as main risk factors for loss of independence in an aging population, as we face it in most of the part in Europe and in the developed countries. Now, this is a little bit a busy slide, and especially the right side, you will have all the slides virtually to go into details, but I think the major part of this presentation is that to combine declines you see both on a physical but also on a cognitive basis in older person. It's part of normal aging, but it may deviate from a normal aging process, and then it comes to be a problem. So we would like to screen this early, because if we want to prevent cognitive function decline in older persons, we have to be early. And this is important because loss of autonomy is one of the major problems in older people. And if you ask older people what they expect from you, it will most of the time not be survival, but stay independent, having autonomy to be socially embedded. So, as in many instances dealing with older persons, you see in the mild frailty and cognition process, it is not just a binary thing, an effect due to a starting point, but it's a syndromic. A syndromic approach, meaning that different parts could be involved to develop cognitive and physical decline. And they are pointed out here. It's a chronic inflammation process starting on the top, inflammation. It's impaired responsive of the hypothalamic pituitary axis. Then, first of all, energy homeostasis dysfunction, endocrine dysfunction, mitochondrial dysfunction, oxidative stress. You will speak about that when it comes to treatment with physical activity and nutrition, genomic factors, and metabolic markers. We more and more go to look into it. So on this third slide, we more go now into the dietary intake and functional capacity. And as you see here on the top, inadequate dietary protein and energy intake is one of the hallmarks when it comes to function decline in older persons. And this may be due to either not taking enough per se because you have no hunger or you are depressed, but also if you have a cognition problem, you probably forget to eat. So this leads to reduced muscle mass, basically sarcopenia, which has a close link to the frailty syndrome from a physical part, and then you have loss of strength and oral muscles. Mastication can become a problem, or has deficit, and as you see, it's like always is a vicious cycle. On the right side, just for one example, it's a vitamin D. There could be also other ones. The hype of vitamin D is probably a little bit over, but again, vitamin D intake, which has also due to problems with the muscle, then you see it comes to low physical activity, and the less physical activity you have, the more you will also have problems with your functionality. And this, something like a little bit a more easy slide, is that if we speak about physical frailty, one of the hallmarks as a geriatric syndrome, we focus most of the time on the physical frailty, probably diagnosed by the Fried criteria. But always there is another dimension of frailty, which can be outside social isolation, not having enough money, and then the psychological part. And that's the main thing that I think in the future we should more go on a combined approach between physical and psychological frailty, because if we just look for one of them, we will miss opportunities to prevent or treat it. So what are now the potential biomarkers between physical and cognitive frailty? And you see here a whole palette of things, starting with IL-6, the interleukin of the elder, TNF-alpha, we have spoken about already, the inflammation process. But I would say you see that there is a great amount of research just now, but for those working more on a day-to-day basis in a private office, being general practitioners, this may be too advanced. And so we need in the future easy way to look for biomarkers and also screening tools for physical and cognitive frailty. And there are, as you know, so for the physical frailty, I alluded already to the 3 criteria. For nutrition, you can use the MNA. The short form, even in those 6 questions, you have 2 questions about mobility, so functionality, depression, and problems with cognition. So it's more an inclusive, easy tool to look for frailty. You may have seen that there is a small misspelling, not in the bottom with biomarkers, but on the heading. I'm sorry for that, biomarkers. And I think really it's a good misspelling, because I think to prevent loss of autonomy in older people has a lot to do with markets, because if lose autonomy, people need to go to a nursing home or so on. So it's not just an issue for the person involved, but also for society. Now, what can you do for identification and treatment? Early identification for functional and cognitive decline is important. I already alluded to some of the possibilities. Another one for cognition often used is the MMSE. As you know, there's a clock test. So we have those screening tools, but they are not used to the amount I think they should be. Even in, I would say we always take blood pressure, but I think 1 time per year we should go to look for cognition, for nutrition, for functionality. So it's a multi-domain intervention and follow-up for re-evaluation. I just told you you should do that in a regular sequence. And what can you do? So exercise therapy is good for functionality on the physical part, but more and more also for cognition. Nutrition intervention and treatment of malnutrition is present. If you have it, there are tools, as you know. Cognitive training is also effective. Social engagement is extremely important. As you see, if you look for longevity in all society, there's always a trias, which is physical activity, nutrition, and social involvement. Then treat comorbidities if present. This mainly goes for, problems with cardiovascular diseases, because vascular dementia is often combined with, for example, classical Alzheimer's disease. Address polypharmacy. Look if you can do something like deep prescribing. And then what is also now captured more when we are going to looking for intrinsic capacity by the WHO, we also have to look for sensory losses like vision, hearing, and also to look for sleeping disorders. So to sum it up, declines in both physical and cognitive function are associated with increasing age. It's part of the normal aging process. But function and cognitive decline are associated with increased risk of poor quality of life and autonomy. And loss of independence is the danger people will tell you when they get older, they fear it. Chronic inflammation, impaired endocrine, stress responsive due to the hypothalamic pituitary axis, imbalanced energy metabolism, endocrine dysfunction, loss of growth hormone, for example, or sex hormones, during the aging processes, mitochondrial dysfunction, oxidative stress, it is something you can both counterbalance with physical activity and for sure with a Mediterranean diet, for example. Genomic markers and metabolic markers are major underlying mechanisms between physical frailty, muscle more, sarcopenia, and cognitive decline in the brain. Early identification of treatment of function and cognitive decline prevent disability in an older population and may improve independent function and quality of life. As often when dealing with older adults, this is a multi-domain intervention. Then it's mainly successful. So it is a suggested way to improve independent function and quality of life. Having said so, dear colleagues, I think we should also not underestimate that autonomy, quality of life is also always dependent on the part you live in, the environment you live in. So it may also with a certain loss that you have a high quality of life. And with that, I thank you for your attention.